Good morning, everyone. Welcome to Grand Rounds. It really is an honor and a pleasure to introduce our speaker for this morning, Dr. Ralph DAMIANO, who is truly an international leader in cardiac surgery, perhaps one of the few remaining true surgical scientists. Dr. DAMIANO trained at the prestigious and rigorous Duke surgical and cardiothoracic surgical training program. Currently, Dr. DAMIANO is the Evarts Graham Professor of Surgery at Washington University in St. Louis in Barnes-Jewish Hospital. He's the co-director of the Heart and Vascular Center and truly is an internationally respected leader in the surgical treatment of atrial fibrillation, and that will be the focus of this topic this morning. So with that, I'll introduce Dr. DAMIANO.
Thank you, Tom, and it's a real pleasure to be here at Houston Methodist DeBakey Heart and Vascular Center, such a prestigious place that has made such huge contributions in the field of cardiothoracic surgery over the year, and it's absolutely great to be here. And I'd like to talk to you this morning about an area of special interest to me, which is the treatment of atrial fibrillation. We've been very involved in that over the last 30 years. And I'd like to share with you some of our insights, but particularly to try to look and focus on the treatment of atrial fibrillation in patients with valve disease, particularly mitral valve disease, because these are patients that commonly are coming to surgery. And I hope to show you over the next 45 minutes or so how the field still has a long way to go. The first surgery for atrial fibrillation was done in St. Louis about 30 years ago, just over 30 years ago, and it's termed the Mays procedure. It's been modified and altered over the years, but still remains very effective. Yet despite having done surgical ablation for atrial fibrillation for so many decades, the field still remains quite confusing, and I hope to shed some light on that and perhaps a way out of the conundrum which we've had. These are my disclosures, and I'd like to start just by acknowledging my research team, both in the basic laboratory and clinical research team that have done most of the work I'll show you. We've been really led over the years by the lab director, Rick Schuessler, who helped develop the original Mays procedure with Jim Cox. And we have a lot of collaborators in radiology and engineering and cardiology that have really helped do all this work. Probably who I really need to thank these are the lists of the fellows and medical students over the last 10 years who really have done a lot of what I'll show you and got it into print. And then I would be remiss not to thank the NIH, which has funded our R01 on surgical treatment of atrial fibrillation for 32 straight years. So why talk about mitral valve disease? If you really go to most talks on AFib, they talk about lone AFib, particularly in cardiology conferences. Well, the problem, I really think this has been ignored, and part of the problem why we don't treat it all that well. It's one of the most common causes of AFib in the world, and in fact, in patients with rheumatic heart disease, about 30 to 40% will develop atrial fibrillation. That still remains a huge problem, particularly in Asia. In degenerative disease, if you have a flail leaflet, about 40% of people just followed will develop AFib by 10 years, and I'll talk to you a little bit about our work in that population. But what's interesting, there was a global survey published a few years ago looking at almost 10,000 patients. The most common comorbidity, if you had permanent or long-standing persistent AFib, was valvular heart disease, making up over a third of the whole population, the most common cause of long-standing persistent AFib in the world. Yet it has been almost void of any real mechanistic research of why people with valve disease develop AFib. Everyone has lots of theories, but there's been very little work of either why it mechanistically develops and how we could potentially prevent it. When we look at our own volume, this was a paper we published back in 2011, but it's true today. If you look at patients, these are patients referred to Washington University for cardiac surgery, and about a third of our mitral population had a preoperative history of AFib. But interestingly, if you look at this, if you look at the CABG population, 10%, but it makes up such a big part of our volume. But you can see if you had a CABG in a mitral valve procedure, almost 30 to 40% of patients had atrial fibrillation. It's an incredibly common comorbidity. And not surprisingly in the United States, it's the most common indication for surgical ablation of AFib, making in most surgical series up to 30% of patients. If you look at the volume, if you look at that percentage outside the US and Europe and in Asia, that number can approach over 50%. So it's the majority, the most common reason for surgical ablation, and outside the US, probably the most common reason for surgical ablation. And as I was saying, despite 30 years of taking care of AFib, and I'll show you, this is one area in surgery we have a lot of both randomized and non-randomized studies. The treatment of AFib in this group of patients remains both controversial, confusing, and underutilized. So let's look at first the problem and why that is. So first of all, it's why would you even do AFib ablation if someone's coming in with a flail posterior leaflet, for instance? Well, first of all, AFib has a really significant impact on late survival following mitral surgery. And I won't show you the data because we have to get through it here in 45 minutes, but that's true for coronary bypass grafting. It's also true for aortic valve replacement. It's true for everything. Preoperative AFib affects late survival. And this is just one of many studies from Mark Gillinov at Cleveland. And this is looking at a bunch of patients after mitral valve surgery if they had no AFib as opposed to having AFib. And you can see a pretty dramatic difference in late survival. And just like you'd expect, and I'll show you some data from that we recently published looking at this, and remember this curve, this continues to diverge with time, just like you'd expect if AFib was one of the principal drivers of late mortality. It shouldn't be an instantaneous thing, but a progressive thing. So first of all, that's one reason why surgeons, it's hard to know if you're coming for a mitral repair to leave the AFib alone. Particularly, you do not want to be on this lower survival curve. And what about other besides survival? Well, there are some really good retrospective studies that have shown that if you treat the AFib, particularly if you do a maze procedure, you not only are able to restore sinus rhythm, but you can decrease stroke rate and improve ventricular function. I'll show you just a little look at this data. This is an older study, but one of the largest in the literature of about 363 patients with degenerative mitral valve disease and preoperative AFib. And about 160, a little over 160 had a maze and about 200 did not, and they were followed for a mean of over 4 years. But it wasn't just survival, which was better in terms of, in this study, freedom from cardiac death, but also freedom from stroke, 98% in the maze group, but only 83% in those who didn't have ablation, and better ventricular function in the people who had their atrial fibrillation treated. Albeit a retrospective study, I think it does provide some evidence, and it's very hard in this day and age to do any prospective randomized trials after we have an operation that I'll show you works about 80 to 90% of the time in restoring sinus rhythm. We recently, and this we published this year, looking at our group of patients. We examined just under 11,000 patients who were seen at our institution, and we tried to do, we follow all the AFib patients prospectively, but this is clearly a retrospective study, but try to correct for our selection bias. We did a rigorous propensity match of these patients with 22 different variables that were found on univariate analysis to affect late survival, and using a 1-to-1 match ratio. And we were able to come up with, and I'll just show you this data, 342 patients who had a maze matched to 342 relatively identical patients who had AFib and were not treated, and looked at their late survival over time. And in this group, the maze group is shown in blue, where the untreated AFib group in red, and it looks very similar to that slide I just showed you from the Cleveland Clinic, looking at AFib versus no AFib. And you can see that by 10 years, there was a 20% survival advantage. And again, it's very believable that we matched well. The 30-day mortality in this group was identical, and you can see these lines continue to diverge like you'd expect if actually restoring sinus rhythm, getting rid of AFib does impact survival. So I think there is some very good evidence that it's not just putting someone in sinus rhythm, preventing stroke, but it's actually improving survival. And there's been a couple other studies, retrospective propensity match, which have shown now the exact same thing. We also matched a group of over 400 patients who had MAs to fairly identical patients with no AFib, and the survival in the treated AFib was exactly the same as if you never had AFib. So I think that's another bit of evidence in favor of doing ablation. So you could argue still a big group of patients in the US come for surgery, are having their chest opened in various different ways of access and still not getting surgical ablation. You're going, how could that be? You know, it potentially improves survival and may decrease stroke rate. Maybe it just doesn't work. Well, that's not true either. And this is an area we have a lot of prospective randomized trials. Surgical ablation definitely significantly is better at restoring sinus rhythm than doing nothing. And you'd expect that, I would hope, but we have a lot of randomized trials. So these are 7 randomized trials, albeit some of them relatively small, that looked at whether you had a better freedom from AFib with surgery versus no surgical ablation. And every one of these historical randomized trials showed a significantly better freedom from AFib with surgical ablation. Now, some of these were Mays lesion sets, some were not, but regardless, almost whatever you did, it was better than nothing. Probably the most powerful study that has been done in terms of being well designed was this prospective randomized study published in 2015 in the New England Journal, where they did randomize 260 patients with AFib to either not getting any ablation, that is mitral surgery alone, versus mitral surgery plus ablation. And they showed while the success rate wasn't very good in this trial, and there's a lot of reasons for that, still it was better than nothing. And this was, you know, highly significant in terms of freedom from atrial fibrillation at 1-year follow-up. So I think there's convincing, and this is one of the few areas of surgery where it's prospective randomized evidence that it's better to do ablation than not to, particularly in terms of restoration of sinus rhythm. So still, why are a lot of patients not getting anything? And there is a feeling that surgical ablation adds to morbidity or mortality. And that really is not true. And in these 260 patients, again, it's a small trial, but there was no difference between the no ablation versus ablation group in terms of major cardiac and cerebrovascular adverse events, readmission, or mortality rates. So adding ablation does not add to morbidity and mortality. And in fact, I won't show it, but the recent look at the STS database, and it's a very flawed study. I was an author on the paper, but it actually showed that if you did ablation, you had a lower 30-day mortality, probably due to still selection bias in terms of doing ablation, but whatever, even in the big registry studies, it does not add, it certainly doesn't add to morbidity or mortality, and there's some evidence that it may actually lower, particularly early mortality. So I would say we have a pretty good treatment imperative in this group in that AFib is common. Over 1/3 of the patients have it. If you don't treat it, they have worse late survival and likely a higher stroke rate. And we have multiple randomized studies showing that AFib ablation is both safe and effective. So you'd say everyone should be getting it, but no, it's not the case. So let's look at where we are in 2018. So first of all, you know, what should we do? The most effective gold standard in terms of surgical ablation is the Cox-Maze procedure, which I've referred to, and how effective is it in patients with mitral disease? And the answer is fairly effective. And like I said, the Maze procedure was first done in 1987 at Barnes Jewish Hospital by Jim Cox, shown here. And it started out to be quite an aggressive operation with a lot, this is a cartoon look at it. It was a lot worse in real life, but just a myriad of different incisions on the left and right atrium that were designed to pretty much, we couldn't figure out what caused AFib, so this was done to prevent all types of AFib. The reality was this was too complicated. It really worked well, but it was too complicated for most people to do, and really even at its height, and just at the beginning of the millennium, 1999, 2000, it was estimated that only about 400 cases, these cases were done worldwide, and most in just a handful of centers. But that's really changed over the last 15 years with the introduction of ablation technology, which is, instead of doing surgical incisions, using ablation devices to create transmural scars has decreased the invasiveness of this and really, I think, revolutionized the surgical treatment. It's much different in 2018 than it was in 2000. And it certainly has made doing this in less invasive approaches much easier. Now, we've spent a lot of the last 20 years looking at different ablation devices and testing their effectiveness in the laboratory. And the two best devices after a lot of testing were these bipolar radiofrequency clamps in which the electrodes are embedded in the jaws of the clamp. They're very effective, very quick, and are really good at creating transmural lesions. And cryoablation devices, which can be either, here shown our old reusable probes, and the more common now disposable probes. And we use these two very effective ablation devices to introduce a modification of the maze, which we call the maze 4. The original cut and sew maze went through 3 iterations. And this was using the bipolar clamps that I showed you in cryoablation to basically perform the maze procedure. And depending on your approach, you can do it through either 1 small incision or 2 small incisions. And that has now clearly, it's been the most commonly performed procedure in the world for AFib, and it's the only operation, including the original 3 versions of the maze procedure, and the only technology that has been approved by the FDA to actually treat AFib. So I don't have to discuss this off-label anymore. This is on-label indication. So how does it do in mitral disease? And this is a paper that we published back in 2012 looking at our results in mitral comparing to lone AFib. And really the short answer is it works just as well in mitral patients as lone AFib. It's an extensive lesion set. And when you looked at it 12 months, just about 84% of patients were free of AFib completely. And this was mostly judged by long duration monitoring of at least 48 hours, 24 to 48 hours. And just under 80% were both free of AFib and off medication. I'll show you, this was early in our experience. Our present results after we looked at this data, and I'll show you some of the data on how we originally did the maze 4. We put in a modification which we realized about in 2008 that it wasn't effective, but it sheds a light into the mechanisms of AFib in this population. But actually it works pretty well, and you can see this is, and these results are really maintained out to 5 years. I'll show you some of that data. Can you do it minimally invasively? Because most people really aren't excited. A lot of mitral surgery is being done minimally invasively. Can you add the maze? And the answer is yes. We do it through a right mini thoracotomy when we do a mitral maze. We use femoral cannulation. We do not do any rib spreading. We just use a soft tissue retractor. You really get a good cosmetic result. This is the incision from here to here. And we looked at whether, if we did it through that small incision with thoracoscopic guidance, is the maze, can we do the lesion set as effective as a sternotomy? And you know, I probably wouldn't be showing you this if the answer was no. The answer is yes, you could do it just as effective. And this is also, I'll be talking a little bit more about this at the Re-Evolution Summit of how you do it, but just in terms of the results, you can see that at 2 years, the freedom from recurrent atrial arrhythmias, again, 3/4 of these patients had some type of prolonged monitoring and was over 80% in both groups. We're still free from AFib. Yellow is sternotomy, red is the mini thoracotomy. But you can see it's very good, and like I said, even out at 5 years, it stays just about at 80%. So it's very good at restoring sinus rhythm. And that's really regardless of what type of AFib you have. So I think it's not surprising with the prospective randomized and the really excellent retrospective data we have on this, that in the present HRS AFib guidelines, that treating AFib in patients who are coming for mitral valve surgery now is a level 1, highest level of recommendation in the guidelines. I think it's in the mitral population, it's 1A if they're symptomatic. So we have very good evidence for that, and we now have strong guideline recommendations to do it. So what's the sort of, I think that's great. We've made some progress over 30 years, but if you want to look at the bad side is the majority of these patients are still not treated, and not only that, most patients both in Europe and the US receive a lesion set that really hasn't been studied, and that most people in almost all the big registry series just get pulmonary vein isolation. So let's look in the US when, this is a study published last year looking at the STS database from 2011 to 2014. And while the number of patients getting treated has improved, again in 2000 that number was so low that we're getting ablation that it couldn't even be measured. And it wasn't even part of the database. So in just under 20 years, we've gone from virtually nobody being treated to about 60% of patients now who have AFib receive concomitant ablation. But if you look on the other side with that kind of evidence, that's 40% of patients aren't getting, as if it would be as if a coronary series, and if you if your bypass series last year, 40% of patients didn't get a left internal mammary graft, you probably would not be getting any referrals. So still a good percent of patients get nothing. But then even the more tragic side of it is if you look what they are getting as opposed to what I've shown you, we've had an operation around for 30 years, we've modified, it can be done quickly with ablation devices, it has excellent results, it's been proven in prospective randomized. The majority just get pulmonary vein isolation alone, which at least I'll try to show you some data that what the little data we have would suggest that it will not work in this mitral population. And this is one of the few really randomized studies that were randomized to look at this, this is a study from Italy. It's small, but it was very well done study with 100% follow-up, and they looked at pulmonary vein isolation versus more extensive left atrial lesion sets. No one really got a maze. But whatever, just pulmonary vein isolation done in this study with cryo worked only 29% of the time, and this was only at a mean follow-up of 41 months. We're not talking out at 5 years here. So really in this study, and there's several other studies that I really won't bore you with, but show very similar findings. But let's look at, I told you our data, and this would be the best. When we first did the MAZE 4, we just put this inferior connecting lesion, but I left out the superior connecting lesion. So if you will, that whole extensive lesion set on both atrium, the only thing we left out was this one lesion right here. Everyone had pulmonary vein isolation, and no one left the OR without documenting exit block from the pulmonary veins. That is, we electrically demonstrate that the pulmonary veins are isolated electrically. But we didn't do that one lesion. So how did that impact late freedom from AFib? Well, it had a pretty dramatic impact. It didn't have much of an impact at a year, though it was significant. But when you got out to 5 years, and this is 576 consecutive patients who either got the box or no box, we didn't do that lesion for about 3 consecutive years. And you can see this would be the best case with pulmonary vein isolation because all these patients also had right atrial lesions, but at 5 years, only a third were both free of AFib and off drugs. The freedom on drugs was higher in both groups, but still significantly worse if you didn't have a box. But there are not many surgical operations I can think of where we would be happy as surgeons with a 30% success rate at 5 years, and probably we wouldn't get many referrals. So this clearly is not a good strategy, and the question is how to improve the MAZE strategy, and that I'll talk about a little bit later. The not doing the box had the biggest impact in the mitral population, which was interesting, and I would not have necessarily guessed that. So when we looked back on that study that I showed you of a series of patients who had a maze in mitral population, univariate predictors of failure were large left atrium, poor EF, and the occurrence of early arrhythmias. In concomitant disease, the only real predictor was left atrial size, that is in patients with mitral disease and AFib. But in multivariate analysis, the only predictor for failure was failure to isolate that posterior left atrium. That's by not performing this one lesion. And that increased your risk of failure by almost 5-fold. I mean, that's pretty dramatic, odds ratio of 4.8. So clearly, if you just do pulmonary vein isolation in mitral patients, you will not get good late success. And that we've seen in certainly our studies. So you'd argue that after 3 decades, all this evidence that I tried to show you, why the confusion? And I will hold that that's because there have been very few studies looking at the etiology of AFib in patients with mitral disease, despite the fact that as surgeons, those are the patients we most commonly take care of. And in the world at large, it is the most frequent cause of longstanding persistent AFib. So I think this is an area sorely in need of some mechanistic studies that would help define what we should do and when we should do it. Most of the mechanistic studies of AFib that you read in the journals are in patients with lone AFib, and certainly a lot have purposefully excluded patients with organic heart disease. So I'd like in the remainder of my talk just to share with you some of our work in the research laboratory, both clinical and in patients and also in animals, trying to understand what is it about mitral regurgitation that causes AFib and what should we do about it. And this is our present R01. And really, we've looked both in dogs at acute and chronic models of left atrial volume overload. And in patients, we've been doing body surface mapping or electrocardiographic imaging to try to understand mechanisms. And I'll go through this, and then we should have some time for discussion. But first, just in dogs, what happens if you have acute left atrial volume overload? One of the problems is we wanted something that's reversible, so you can't just go in and cut the mitral valve, which has been the most common model of people who've cut the chordae. The problem is once you cut them, it's been very hard until recently, maybe with some of these percutaneous chordal replacements, to get it to stop leaking so you could see what the recovery is. So what we've done is develop both in this acute model and then a little more elegantly in a chronic model, a shunt that we put between the left ventricular apex and the left atrium. And this is just the example in this study. And then use that. We can titrate this shunt to create a shunt fraction of 40 to anywhere up to 60% is actually surprisingly tolerated pretty well in animals. And then look at the acute effects. Now, you would think acute MR, we have to know what the effects of that are acute, but actually the literature on that is incredibly confusing because, looking at it in isolated little Langendorf prep as opposed to a whole model is probably very different. Actually even that area has been controversial. This is a study we published a couple years ago where we looked at the effects of acute left atrial volume load or a surrogate for MR, and clearly acute, this is baseline, and red is maximal left atrial pressure, and green is mean, and you can see you get a marked increase with the shunt open in left atrial pressure, maximum left atrial pressure, and when you close the shunt, that reverses. That also results in an acute increase in left atrial volume. The electrophysiologic effects of having an immediate shunt fraction of just under 50% were not very dramatic, actually, but there was a significant increase in atrial conduction time, which we'll term TAT here, but we didn't see any changes in effective or refractory period or inhomogeneity, which just says, we have an indice to look at how homogeneous the conduction is across the atrium. If it's a nice steady and homogeneous wave of activation, or it's very inhomogeneous, which has been associated with arrhythmias. And you can see this is activation, red being early and blue being late, with the control left atrium, and then you can see more blue as you open the shunt, so the total atrial conduction time increased, and that was significant in every, and then returned to normal with the shunt closed. But that was about all we could see, is probably whether it's related to stretch. We're still looking into that, but the bottom line is their ability to induce AFib did not change between baseline and with the shunt open at all. There was no increase. So acute mitral regurgitation is not proarrhythmic. So that led us to look, or to conclude, that chronic left atrial volume load had to be necessary for the development of a substrate for AFib. So I'd like to show you this, and this is in press, but I'd like to show you some of our data with this. And I think we have a really good model of left atrial volume overload that may shed light on not only the atrial remodeling, but also the ventricular remodeling. And we're in the midst of looking at all this data, but I'll show you, this is a study we've done, and it's taken years to do because we initially did not want to have a 6-month. We planned on just a 3-month study, and that's expensive enough. But at 3 months with volume overload, you just don't get enough atrial changes. So we've had to go out to 6 months. And the unique part about our study is, sorry, let me just go back. We also had a sham group where we did the instrumentation, we never opened the shunt. So we did 10 dogs as sham, so they all had operations and then were survived for 6 months and then sacrificed. And then we had 10 dogs where we survived them for 6 months and sacrificed. We're still, we haven't actually started this reversibility part yet because we're still looking at all the data from the first 2 groups. So we'll compare those animals, and they had a shunt fraction of between 40 and 50% in this data that I'll show you. And this is a look, this is instrumentation. We put this into the apex and then sew it to the left atrial appendage. And this is a look at this shunt. It took us a while to get it, and we have to thank Dr. DeBakey and his graft material for this. But we used a combination of PTFE and woven Dacron. So that's just a look at it. This is at 6 months. Our average shunt fraction was 46%. No dog had clinical signs of heart failure, and this is just a look at the left ventricular side, and you can see these shunts really endothelialized well, and we did not have any thrombosis once we were able to, it took us about a year to come up with the right way to manufacture these apical to atrial shunts. And I'd like to just show you, this is a TE at 6 months. This dog had a 3-centimeter atrium, and you can see at 6 months it was up to 6. And there is the flow coming through the shunt. So you can see the jet mimics MR. Interestingly, over time, some of the dogs developed real MR, and this is a look at the flow in the shunt at 6 months. We also did MRI, and I'll show you a little bit of data on that because we're interested in that from a way to define the mechanisms. And you can see here is the shunt. We can also see, which was interesting, and we weren't expecting it, this ventricular function. There was a big impact on ventricular function in the shunt dogs of having a shunt fraction of 50% for 6 months. And let's look at the physiologic data first. You know, as we were hoping, we saw a progressive increase, just almost a doubling of left atrial volume over time. But interestingly, and this was not quite expected in the shunt dogs shown in red, we saw a progressive and highly significant decrease in left ventricular ejection fraction. And that was not seen in the sham dog, so it wasn't just from having your apex instrumented. We also have done pretty extensive electrophysiologic studies mapping these dogs both at baseline and 6 months with these form-fitting custom-made epicardial plaques with 250 bipolar electrodes. I won't bore you with a lot of it, but we looked at effective refractory periods and also different measures of conduction. And this is just, again, the sites we looked at ERP from both left and right atrium. But the first thing we did see, which was interesting, and this was similar to the acute MR studies, which I showed you, is that atrial activation time significantly increased. And this, again, total atrial conduction time. And these are the activation maps, again, red being early and then going to blue, which is late. But you can see, and this is the same animal pre and post, you know, very much slowing of conduction, a lot more blue colors. And that was true for the whole group. But as opposed to what I showed you acutely, now not only it was slower, but it was much more inhomogeneous, I should say. And that is what predisposes you to arrhythmias. And the reason for that, we have some hypotheses, but you can see here that you have a very nice, nice wave of conduction which activates the atrium here. But here it's much more broken up and the lines are much more curvilinear, if you will. And we have a way to quantify that by looking at phase difference between different electrodes. And not in the sham group, but in the shunt group, the index of inhomogeneity for the left atrium was significantly higher after 6 months. Also interesting in this study was that if you looked at effective refractory period, it had dropped. And lower effective refractory period is definitely proarrhythmic. And compared to the sham animals in yellow, the shunt animals, both in right and left atrium, had significantly shorter effective refractory periods. And what we did show was, as opposed to the acute model, now we could really induce AFib. And this is a log scale. So it's more impressive than it even looks. At the time of induced AFib, here it's only about 10 seconds in the sham, and in the shunt group it's up at 1,000 seconds. And we had one animal go into AFib and stay in it, but most of the animals, you really have to pace them into AFib. Now, what was interesting in these, we used MRI to do scar mapping, and so we definitely have the substrate, and this is a 3D picture of the atrium, and I'll let it just kind of rotate. And the light green, if you will, is areas that were defined on MRI with late gadolinium enhancement of being scar. And I'd just like you to compare this, and this is the same animal after 6 months with the shunt open. And not only do you get a lot more scarring, going from 1% total to 8%, but that scarring seems to be, which is interesting and maybe mechanistically important, most of the scarring seems to be focused on the posterior left atrium and particularly around the pulmonary veins. It's pretty interesting. And that was the effect we've seen. And like I said, this is impressive. We quantified this with histology, and we showed that around the pulmonary veins, the amount of fibrosis you get in this model it's not widespread, it's patchy, but that's exactly what we see in people. So we think it reflects probably the clinical situation pretty well. And certainly when we looked at the percent fibrosis around the left pulmonary veins, comparing sham to the shunt, it was significantly higher in the shunt group. And what's very interesting is that this area of fibrosis seems to also be an area of where you have a lot of inflammatory cell infiltration, which suggests potentially a mechanism in patients with MR of trying to prevent the development if you could somehow blunt this inflammatory response. And that's really what we're looking at in our upcoming grant renewal. So I think we've developed a controllable, and it is a reversible canine shunt model. We haven't looked yet at reversibility of these changes, which would be very interesting because there may be ways we can predict that if a patient was referred to you and they just had one episode of AFib, you could do perhaps a scar map, and I'll show you some of our data with this body surface mapping and say, don't do it. The substrate isn't bad. If you probably correct the MR alone, they'll get better. There are other patients that we maybe could tell you that even though they had no documented AFib, you maybe should do an ablation. So we think that a better understanding of the pathophysiology of AFib in patients with mitral regurgitation would help to both optimize the timing, but also the type of surgical ablation in these patients. So what I'd like to end with is just some work we've done in patients who were referred to me for mitral valve repair. And what we did to try to understand, and hopefully you'll see that what has been, I think, gratifying is our data from our clinical experience has very much mimicked what I just showed you in animals. So I think our model may help let us look at reversibility and mechanisms pretty well. But what we did is use electrocardiographic imaging. This is the Cardio Insight system, which presently is commercially available. And it's what you do in this is and this is a patient right here in the upper left-hand corner wearing a jacket of electrodes. And we take the electrical activity from the surface, and using CT scan or MRI, either one can be used, but using anatomic information, we can take those body surface potentials and recreate finally an activation map or frequency analysis of electrical activation of the atrium, both in sinus rhythm and in AFib. It actually works quite a bit better in sinus rhythm, as you can imagine, but you get a lot of data either way. And I won't go through, just from a time standpoint, the data processing, but I'd just like to show you our results. We had 4 groups of patients. I'll show you normal, healthy patients, about 20, most of them medical students. We're trying to get some older patients now, because that's the one problem with this study. But and then we looked at patients referred with all had severe MR, either no AFib, paroxysmal who were in sinus rhythm at the time of mapping, or in AFib at the time of mapping. And we did ECGI, or this body surface mapping, prior to surgery in 3 to 6 months. And we looked at a lot of different parameters, but I won't bore you, but we looked at activation, total atrial conduction time, which is important both on the left and right. We looked at amplitude of the signals, which some people are using for perhaps a marker of fibrosis or bad atrial remodeling, and we looked at fractionation and inhomogeneity. And I'll just really talk about inhomogeneity and total and atrial conduction time, because that's what we talked about first. And this is easily, I'm sorry, one of the worst slides ever, but I'll just, with red, show you that the main things to look is left atrial conduction time was significantly prolonged in patients with AFib and mitral regurgitation, and they had more inhomogeneity of that conduction. So it was slower, and it wasn't as organized. And this is activation sequence maps in a normal control, and you can see very nice homogeneous activation. And this is one of my patients with MR and paroxysmal AFib, a lot more blue, and you can see it's broken up conduction. It doesn't look normal. We also did again, we looked at conduction heterogeneity by looking at the distant normalized maximum phase difference between each point and its neighbors. You can just forget about that now, but we did, again, get this index of how heterogeneous the conduction was. And also, I'll just say, if you're really dark blue, it is very homogeneous. And as you get lighter, it becomes more heterogeneous. And this is normal controls. This is bad MR. And you can see there's this area, even in patients with MR, and this is AFib and MR. And you can see conduction becomes more heterogeneous. And that was a very common finding, and we may be able to use this data to guide or to give some rationale for an ablation strategy. But what we found, which was really interesting, is this area of conduction block in the posterior left atrium, which was not unusual, and we verified this. It actually, you see it in some normal controls too. We verified this now. We've done some intraoperative mapping to make sure this wasn't some just unique aspect of body surface mapping. But you see this area of very slow conduction in the back left atrium. These are the two, this is the left pulmonary veins and the right pulmonary veins. So this is a line of block that seems to go across the posterior left atrium. And here's another patient also. This is a patient who had PAF, and this is a patient with severe MR, but a big left atrium, but no AFib. but you can see this line of blocks. So this could be why not doing a box isolation is bad, because there's really slow conduction of the back of the left atrium. We also saw occasionally, this is a patient with moderate mitral regurgitation who seemed to have a paroxysmal AFib originating from the right veins. And if I had known that before I did the surgery, this might have been a patient where just isolating those, the back left atrium would have been a good strategy. Similar, we took biopsies of the left atrium in all these patients when they came to surgery, and you can see there was definitely significantly more fibrosis in patients who had AFib compared to who did not have AFib, both having severe MR. So it appears that fibrosis, as it may be a marker of substrate remodeling in low AFib, may be a really important marker in these patients, and that's what we're exploring right now. And particularly what we're doing now is we're gonna use, instead of CT, MRI to do get us the anatomic information for ECGI, and then do a combination of scar mapping and electrical mapping, and then hopefully use this as a way to both let us know when we should intervene and then how we should intervene. So I think there is some hope. We still have some ways to go, but for the first time we may have some mechanistic information of why patients with volume overload get MR. And certainly if we could perhaps prevent some of this remodeling, we could, in patients with severe MR, we could obviate the need for even doing ablation. But particularly, we think this is going to be really helpful for patients who referred for surgery who already have AFib. So in conclusion, I hope I've convinced you here this morning that surgical ablation for AFib at the time of mitral surgery is safe and effective. And it's been convincingly shown with level 1A type evidence that it is really good at restoring sinus rhythm compared to doing nothing. And we now have, I think, some more convincing data that it will improve late survival. And I think as surgeons, it's really still, it bothers me that not only still 40% of the patients aren't being treated, but when they're being treated, almost the majority of people are getting an operation that really has no justification. That's just pulmonary vein isolation. And I think we have a once-in-a-lifetime opportunity to cure AFib at the time of mitral surgery. And I think as surgeons, someone said earlier we're trying to compete with the cardiologists. We're not. These are patients referred for surgery. I mean, we just have to do a better job of that, and we have a ton of evidence. But that said and done, we don't have good mechanistic evidence. We don't have a really good preoperative diagnostic study that tells us what to do, like we do with echocardiography with valvular heart disease, which defines the absolute etiology, for instance, of degenerative mitral regurgitation. We don't have anatomy like we get from cardiac catheterization or IFR for coronary disease. But I think there's some hope now with a combination of two non-invasive studies, MRI and ECGI, that will not only be able to better define the mechanism of AFib, but also design more effective ablation strategies. Thank you very much, and I'll be happy to take any questions.
Well, thank you very much, Ralph. That was really a great talk, and you and your group have done more to advance the field, certainly the surgical field of treatment of atrial fibrillation with, not just with mitral valve disease, but other types of surgical treatments of atrial fibrillation. And also want to thank you for sharing your elegant and really comprehensive investigation into those experiments. It's certainly from the surgical literature, there's a lot of confusing reports about what is the appropriate lesion set. And you've demonstrated that the Cox-Maze 4 procedure is easy to do, it's reproducible and durable. One end of the spectrum, people talk about just clipping the atrial appendage. Can you, and thinking that's a surrogate for atrial fibrillation operation, can you talk about that a little bit?
Yeah, I think there's the big confusion now. I think we're really down now to, well, I mean, there's multiple camps, which is surprising to me, and a lot of very experienced people. So first of all, I think that the big side of nihilism would be just saying, just clip the appendage and get out. I think we're well past that. I mean, I can't imagine anybody would would do that. Yes, I think that would have an impact on their late stroke, but it doesn't restore sinus rhythm. And, I think, in my opinion, except in elderly high-risk patients where I think it could be in patients who you do not want to do ablation for various reasons, perhaps they're too risky, perhaps you think that, the atrium are so big or you're going in there doing a double valve and you don't want to add anything. I think clipping the appendage in the elderly particularly is reasonable, but as a strategy overall, it seems very misguided. You have to, probably when I talk to electrophysiologists, we have the perfect ablation environment. Any electrophysiologist would be incredibly jealous of what we have. When we do mitral surgery, we have the patients on bypass with an empty heart. We don't have to worry about blood. We don't have to worry about, char. We don't have to worry about perforating the esophagus like they do. And we can see what we're doing. You have a perfect ablation environment. So we should take advantage of it. That's what I'm saying. These are one patients. Forget about all the rest. Try to do beating heart, thoracoscopic, lone AFib. These are patients on pump, even through small incisions. We do it for the very small incision. You can do a complete lesion set. I think in those people that, I think right now the big dichotomy is between pulmonary vein isolation alone and, a full maze. And, a lot of surgeons did not learn the maze. They still feel it's fairly complicated. I think our data shows that just pulmonary vein isolation alone just cannot be effective. And that you can see, without doing the box, and that's with the rest of the whole maze. So they all had a full right atrial lesion set, and they fail at an incredible rate, 30%, only 30% success at 5 years. I just don't see that a viable strategy in mitral patients. Now, I know that we have this NIH trial, which wasn't designed to look, it was horrible. I don't know how the New England Journal ever let that out. It was not powered to compare the maze to PVI, but it did show, many of you may know, I didn't show the data. It's so bad that I try to not show it because even in the study they say they weren't powered. But basically they did a sub-analysis. It was not powered, which not surprisingly didn't show a difference between PVI and the maze. So the only thing I could say is, 40% of the patients used ablation technology that no one uses anymore. 40% use unipolar RF, which I can't even imagine anyone using on pump. So the patients who had a maze, very few of them had a actual maze 4. They had some subgroup of it. And then the pulmonary vein isolation group was this mixed group of some had a box, some didn't. They didn't control it. It's just a bad study. They also didn't look at the success rate off drugs, which I was showing you, which was that 30%. Their success rate at a year off drugs was, in the PVI group, was 50%. It's bad. It's what our success rate is with the non-box, to be honest with you. And it's only going to get worse. So, that study, while it did show ablation was better, it's hard to make any other comments from that. But it has a big influence on surgical practice. I would tell you that in either the one randomized study that was powered to look at, wasn't really powered to look at, but tried to look at it, where they randomized them to different lesion sets. And also our data, which while not randomized is huge, and all the patients were done by virtually all, about 98% by me. So there wasn't surgeon variability. I just don't think it's reasonable. But, part of it is we don't have, I think, I was always liken it to the fact that if we had no cardiac cath and everybody with chest pain just came to the OR de novo, and you might say, I just want to do a Lima to the LAD. And I would say, I want to do 4 grafts on everybody. And we would know that if you had no way to stratify patients, you could see in a year that I could probably say that the two of us had no difference. If we had we don't have a very fine look at success either with the maze or ablation. So, I think we need better mechanistic information, which then could guide surgery. We're trying to put together a trial right now in mitral patients where I have equipoise. I don't have equipoise to do nothing. But I definitely have equipoise now in mitral patients with some of the stuff I showed you, that you could just box the left atrium versus doing the maze and see how that does. I wouldn't just do pulmonary vein isolation. I don't think that's going to work. Because even our data shows that the back of this left atrium, for some reason, gets really affected in patients with MR. And it seems to even be more important than even lone AFib, that area. So I think we need more studies, but I think, you know, what's frustrating to me is that people jump on things where it's not like we just started the operation yesterday. 30 years is a long time to be doing something. And we know, they've been followed. It's not like we don't have any data. So I don't know, it's a bit frustrating, but and the other side is we made a heck of a lot of progress. If we had this talk 20 years ago, we'd be talking about no one got anything. So I think that's a positive.
So one thing that is ubiquitous in the ablation literature, be it surgical or catheter-based, is a huge problem of quality control. That you look at a study or you look at an operator experience or a claimed success of an operator and different ablation strategies, you have to assume that at least in each group, 30% of them or more didn't get the intended lesion set. I think that may be one of the problems why the surgical maze may have had less reproducibility than your data would suggest that it's justified. So I think that may be an issue. I had a comment about the appendage story. So in the Gillinov paper, where they took patients with for mitral valve surgery and randomized them to ablation versus no ablation, but the no ablation patients got the appendage taken out. These were patients with long-standing persistent AFib, and 30% of them were in sinus, just with the appendage taken out, which I find very interesting. I mean, you would expect nothing, but still 30%. I don't know if part of it is remodeling from correcting the MR or not. But in EP, there's now this push for isolating the appendage or providing the appendage as a target for AFib ablation by itself. I wonder if you have any opinion about that.
Yeah, it's interesting. First of all, I am very familiar with the EP literature on that, and particularly, I think I was just with Dr. Natali, who's a big proponent of that, and people who fail initially, I don't think he does it on his initial strategy, but people who fail their first ablation, they come back, and a lot of the AFib seems to be from the left atrial appendage. Clearly, and there's a couple surgical case reports of where they've clipped the appendage and they've terminated atrial tachycardia, particularly, not atrial fib, but so I think, as a surgeon and someone who's taken the appendage in a lot of people, my own feeling is it's not going to have much of an impact, and I'll be interested to see. It's hard to know what to make of some of the EP studies because they were doing a lot of stuff besides just the appendage. But clearly, it is a source of, I think it's not debatable whether it can be a source of it appears to be sort of substrate for AFib. So I think it might have a role. Now, I would have to say in that trial by Gillinov, and if we went back and looked at some of the other randomized trials, the success rate of doing nothing in almost all these series is in that 20-ish%, and as high as 30% in one series. There's been one series that was done that was even higher than the Gillinov. I'm not that surprised because his study actually wasn't all long-standing. It was all non-paroxysmal, but they included anybody which I thought was a flaw of the study. They included anybody who was called persistent. But if you have AFib for 48 hours and require cardioversion, you're theoretically persistent. So, I don't know what the problem is still the way you get into these trials is very hard to know. If you come in with an acute, you've acutely ruptured a cord and developed severe MR and you develop some AFib and then it goes away with a cardioversion, you would have gotten into that trial, yet you'd never been tried on any drugs. It may have all been related to sort of this, I don't know if I'd attribute that all to the appendage. I would say that that's not that unusual for the surgical randomized trials for the control group. It was a little bit higher, but he's one of the few, that trial put a lot of, it's hard to read, I have to go back to the appendix, but there was quite a number of just persistent patients, not all long-standing persistent. But you're exactly right, that may be a role. I always tell surgeons, you gotta manage the appendage, just to prevent stroke, but also there may be some side benefits that you could prevent, and maybe that's another reason why if you do a complete maze, you get pretty good late results.
Well, great. Thank you very much. Any other questions? I'd like to thank Dr. DAMIANO for a terrific talk.
Thank you.